Well, hello everybody, and welcome back to another episode of GUcast. This is Declan Murphy back here at Peter Mac Studio with my co-host Dr. Renu Neekman. Hello, Renu.
Hello, Declan. Excited about this one?
Yeah, very excited about this one.
You haven't slept, right?
Well, I did, because this topic we're about to speak about, there was another podcast dropped yesterday. Oh, better go and have a listen to that and hear what they said. And, oh, God, more tweets have come out. So, yeah, we wanted to be, right on the button before we invite our special guests on this topic today.
Absolutely. And we've got our Twitter scout with us.
Yes. And so regular listeners might remember a few months ago, we introduced a new segment with our registrar, our fantastic registrar, Dr. Aoife McVeigh. Hi, Aoife. How are you?
Hello. Yeah, I'm good. I'm glad to have you back. Declan,
yes.
glad to be back on the podcast. I feel like the studio's got even more, technologically advanced since the last time I was here.
So. Yeah, probably
more kit.
More kit.
Don't tell my wife. The school fees are going on kid. But Aoife does a regular segment about what's happening on Twitter, and because she's young and more connected, and some of this stuff is to do with GU, some of it's not to do with GU, but we never know. So Aoife, what caught your eye on Twitter this week?
Yeah, so this week it was actually courtesy of our fellow from Thailand, Pete. So he had shared a video yesterday, and I thought it was really, really cool. Obviously in Thailand, robotic surgery is sort of picking up. Pete had said that 3 centres have robots now. I think there's 4 in the whole country. 2 of them are in Pete's hospital, and he's been obviously trained here, and he'll go back and bring his skills there. But to try and promote robotic surgery, there was a really good video of, I don't know if you've seen the TV show, the Squid
Game.
Yes. And there's a task where they have to get the cookie, and they have to get the shape out of the cookie, and that's varying difficulty. And they actually did that with a robot, which was great. So yeah, it's definitely worth a watch. And I think
not quite as impressive as Declan operating on the grape, but it's it's still impressive.
I feel like they may have taken a bit of influence from your great video, but nonetheless, I thought that was pretty cool. I enjoyed watching that.
Fantastic. Well, we'll post that up on the YouTube channel as well for people who want to see. So this is how you promote robotic surgery in Thailand.
Absolutely.
So remind me, what happens in Squid Games in the end? A lot of people die, don't they?
A lot of people die. Yeah, that isn't a happy ending. It's very good though.
But one survives, so that's
one. Yeah.
Okay. Well, we wish the Thai hospitals all the best with that promotional campaign.
Yeah, absolutely.
If it works, we'll all be onto it.
Yeah, absolutely.
Anything else from you, Aoife?
Yeah, no, I don't think anything else controversial happened on Twitter this week at all. It was really quiet.
Which brings us into today's topic. Thanks, Aoife. Sit in if you want.
I'll listen in for a bit and then duck off to theatre whenever I have to.
So that's a good segue to the topic. So you've got a...
Well, it's I feel like it was just yesterday that we all sat here enraged about the fact that NCCN dropped active surveillance as the preferred management for low-risk prostate cancer. And, we sat here and really vented with our favourite active surveillance urologist in the world, Matt Cooperberg. And then months later, when NCCN reversed that, we all were very happy, all was right with the world, but here we are again.
Yeah. So Twitter storm
Enter
first.
Enact.
Yeah, so tell us, should we go through some of the tweets and then we'll find out what it was all about? We'll do it in backwards order.
Oh, absolutely. I mean, it's a little bit backwards, but, the tweets have been crazy. So the attention this has had is incredible. Maria Ribal, I liked it. Very simple. Sincerely shocked.
So maybe we should talk about the trial a bit, because
we should talk about the trial.
A randomised trial was published this week in JAMA Oncology, and
we do love randomised trials.
And we love randomised trials in JAMA Oncology. Yeah, and it was taking an active surveillance population, so men who don't need active treatment, and it was randomised to active surveillance, as we all love doing, as Matt loves doing, versus they called it active surveillance with
plus enzalutamide.
Enzalutamide, which is not surveillance; it's an anti-cancer drug. We'll go through the detail in a few moments, but let's look at the reaction to this study being published.
Yeah, so from Dr. George, has someone redefined the term active surveillance? Jonathan Verma said, we wouldn't accept a study that was active surveillance plus surgery, active surveillance plus chemo, et cetera, et cetera. There's no such thing as active surveillance plus anything. What else is there? There is, Jeremy Grummett from Australia says, subjecting low-risk patients to systemic side effects of enzalutamide is daft at best, cruel at worst. And he also can't get past the no MRI before first biopsy, as a side note. What else? What have you come across, Declan?
Yeah, there was a bunch of them. Somebody's commenting that AS is not treating prostate cancer with low biological potential to avoid unnecessary side effects without losing the opportunity for a cure. using Enza or whatever contradicts the basic principle of not treating. So a lot of people, that was the theme. Hold on, don't call it active surveillance plus enzalutamide. It's not active surveillance, it's active treatment, etc. Mudit Chowdhury, rather, this is using a not cost-effective and not curative treatment with not insignificant side effects. There was a lot of talk about side effects.
I mean, a lot of people had issues with the ethical considerations in this trial.
Yeah, I think some people call that, and a lot of people push back saying, well, hang on now, this was a well-conducted trial, IRB approved, et cetera, but people felt strongly that, look, this is not a trial that should be done, so we want to talk about that side of it as well. Eleni Estasiou said, I'm concerned to consider a pretty toxic from a fatigue standpoint approach, especially for elderly patients. And Clive,
fatigue is not quality of life?
Yeah, and I noticed Clive Peedle, who's a very well-known clinical oncologist in the UK with a very large following on Twitter. Clive was, definitely quite upset about it, and he weighed on in with a bunch of tweets. He comments about the last line in the conclusion. He said, it would be hilarious if it wasn't so serious. Quote, enzalutamide may provide an alternative treatment option for patients undergoing active surveillance. So we're back to that contradiction of, well, hang on, enzalutamide is not active surveillance, etc. It must be retracted, said Clive Peedle as well. There should have been a more appropriate editorial, like from someone who's a radiation oncologist or a urologist who actually manages active surveillance. So we had a little bit of criticism of that. But there you go. There's lots to talk about, isn't there?
Yeah, I can see one of our guests taking his headphones finally off because he's...
Shall we introduce our guest?
We should. Well, our first guest is a great friend of the podcast, Professor of Urology at UCSF San Francisco, Matt Cooperberg. Great proponent of active surveillance. Welcome.
Thank you, I think.
And he did contribute a good Twitter thread as well. You were very good, Matt, well known on Twitter, and you did contribute some good comments on that there as well.
Yeah, absolutely.
So thanks for coming back on. And also, new to the podcast, urologist joining us from Washington, Keith Kowalczyk. Keith, very welcome. Actually, we've got a lot of noise on the line. Should we?
We do.
I don't know, is that Keith's side or Matt's side? Can you guys hear a big hum? Fixed.
All right. Do whatever you guys are doing.
Excuse us, folks. Yeah, welcome.
I feel like we're in Squid Game now. I'm nervous.
Keith, you're very welcome. Keith's a urologist.
See you, Keith.
He's the interim chair of urology and the director of urologic oncology at Georgetown University Medical Centre. And great. Thanks for joining us, Keith. Great to have you on the podcast. And you made some very good comments on Twitter. So it's great to have both of you here. And we want to get Matt to talk a bit about the paper. And then let's talk about some of this reaction, or, let's talk about the way forward, or what good things we learned from this trial.
Yeah, I think, Matt, if you could give us a little rundown of the Enact trial.
Sure. And so first of all, in background and disclosure, I think the reason I got pulled into the Twitter conversation on this, I was part of the steering committee for the trial, and was compensated to a limited degree by Astellas for my role on the paper. I had some input into the design of the trial. I'm certainly not going to lay claim to every word in the manuscript or all the language in the conclusions. But this is a trial that I was happy to be part of because, as you guys already said in the introduction, we are not where we need to be yet with active surveillance, and figuring out better ways to manage men has always been a great interest of mine. Because the fact of the matter is we can say, and look, I may put 95% of my low-risk men on surveillance. That is not what's happening in the country. And figuring out ways to improve patient comfort, clinician comfort, thinking about strategies that are intermediate between active surveillance and radical therapy deserve study, deserve research. And that was my motivation for being involved with this in the first place. So this was a phase 2 open label randomized trial. And let's be clear about that. Nobody is proposing to take this to the FDA. Nobody is proposing to change NCCN guidelines based on this trial, and that was never intent. This was exploratory. It's a phase 2 open label randomized. There were 115 men roughly randomized to receive enzalutamide standard dose for 1 year, 114, 113 in the control arm who were managed with fairly typical active surveillance. Treatment was for 1 year, and then there was a biopsy at 1 year per protocol, and again at the 2-year mark in follow-up. The primary outcome was pathologic progression, so increase in the Gleason grade, or at least 15% increase in the volume of cancer as assessed by the number of cores, or progression to treatment. Secondarily, there was interest in the negative biopsy rates at both 1 and 2 years, as well as progression to treatment. And at the 1-year mark, as men were finishing their enza treatment, the primary endpoint was met. One could certainly argue this would be predictable based on the mechanism of the drug and what's known about AR-directed treatments in localized disease. 46% of the men in the control arm met the progression definition, versus with a hazard ratio of 54 for those on AS, and there's about a 3.5-fold decrease in the 3.5-fold increase in the likelihood of negative biopsy at 1 year as well. Now at 2 years, these differences are already starting to fade. There is a non-statistically significant difference in the negative biopsy rate favoring the enza arm, but again, not statistically significant. And there were predictable side effects, fatigue and gynecomastia being the prominent ones among them, which again, I think would have been, which we did predict at the time of the trial launch based on the many, many thousands of men that have received this drug with advanced disease. This was, I would point out, one of the first times that the drug's been given to men not on ADT. And it was an opportunity to look at the side effect profiles in a younger, healthier cohort than those who have received it through the larger phase 3s that have been done in advanced disease and through the course of standard care in the recent years that the drug has been on the market.
Great.
So that's the overview.
Good summary. And we'll definitely get to the toxicity and all that. But first, the endpoint got a bit of interest, Keith, didn't it? And
pathological, that's an interesting. Pathological progression is the primary endpoint.
Yes. So it was if they, on that repeat biopsy, if they had a change from grade group 1 up to grade group 2, or if they had an extra core involved. And that brings questions about MRI targeting a little bit. Yeah. But, is that a meaningful endpoint, Keith, I suppose is what a lot of people think. Is that a real recognized endpoint? Here's what Vinay Prasad had to say about it yesterday.
This has been basically pulled out of someone's ass because this is not really a thing.
So it's been pulled out of someone's ass.
I wish Vinay would really tell us how he felt.
So, Keith, perhaps a little bit harsh, but what do you think about that endpoint? Is this meaningful for men who...
Can I say something about Dr. Prasad pulling things out of his ass? That's a whole other conversation.
That's Vinay Prasad, by the way.
Go ahead. He's your colleague.
He's a colleague at UCSF.
I know. We can talk about PSA screening and COVID policy and all kinds of other things.
Yeah. And Vinay, he's been on the podcast, and he's a friend of our podcast. So, but that endpoint,
absolutely.
If you've got a low-risk patient coming into the clinic, Keith, do you think this is a meaningful endpoint that worries us? Because that's part of the narrative in the background. I think we're going to see, this. Oh, well, look, come on, patients are worried. And Neil Shore was on a podcast yesterday talking about that. There's a lack of fidelity, and patients are on websites thinking, oh no, you should be treated, etc., etc. Yeah. Is it being driven by something like the risk of the biopsy having a little bit of extra grade group 1 or a change?
Yeah, I mean, it's not pulled out of someone's ass, as Pranay would say. I mean, we obviously, as urologists, look at these endpoints very, very carefully, with the number of cores being positive and all of that to see prognostic factors on whether people are going to progress. So, I wouldn't be that harsh to it, but what bothers me is that if you do have what this study would call a progression, a pathologic progression, they divide it between pathologic and therapeutic, right? And technically you could go from low risk to favorable intermediate risk, and that would be a failure in this paper, as far as I understand it, and correct me if I'm wrong, Matt, but in a large cases, that's not true. We still do active surveillance in favorable intermediate risk disease. So how many of these patients were actually upgraded from Gleason group 1 to Gleason group 2? The other problem I have is this appears to be, this next biopsy was actually what most people would consider the confirmatory biopsy, where these patients were randomized at their first biopsy. At least that's how I read it, Matt, and you can correct me. And we know from Canary Pass, others, that there's upstaging, up to 30% upstaging in some of these patients. So were these really truly a pathologic upstaging, or was this just what they were, just missed disease before? So I do think that the goalposts were set up a little bit here, where a lot of these patients probably still didn't need treatment, even though this endpoint would have been, yeah, we reached our endpoint. They progressed to low to favorable intermediate risk. So it's a good endpoint, but also I think it's very glossed over in the paper. I mean, that's one of my problems with the paper, is that it's very simple, which is nice. I like reading simple papers, but there's a lot of stuff that's left out that I really want to see. And that's just one of them.
Also,
this
that
is
term,
where we need to. Oh, sorry, go ahead.
sorry, Matt, I was just going to say, because that term progression is used quite heavily in this and in the narrative, but you know, many AS people don't use the term progression when someone changes from grade group 1 to grade group 2. When I speak to patients about that, I call it reclassification.
Yeah.
Partly for that reason that Keith just said, because, you know, it's a confirmatory biopsy, and, you know, especially if you've had an MR, and I think a quarter of the patients did have an MR before the second biopsy, you know, you're going to target, you may find that thing versus the random biopsy initially. And it was always there is kind of my way I explain that to patients. Well, it's been reclassified, maybe it changed a bit, or maybe actually this is just the correct thing, and it may not matter very much. But the term progression is a term we use in oncology, and you know, when people have metastases and so on. But I think in the AS population, low risk AS population, I actually favor not using the term progression, and just we describe it as been reclassification, and sometimes that leads to a change in management recommendations and so on. But sorry, Matt.
No, I was just going to say, I think all of this conversation is part of the broader conversation around this trial, which is that this was not a canary pass research study. This was not an academic center research study. And if you think about why this trial was done and in which patients, in which contexts, you know, all of us can sit in this room and easily, you know, argue that all these men, including the Gleason grade group 2s, should have been on straight up active surveillance and would have been absolutely fine. But the fact is, the country and the world even does not really see it that way, and certainly did not in 2014, 15, when this trial was getting planned. You know, at that time, active surveillance rates in the US nationally, according to Aqua data, was still at 30-40% for low risk disease, never mind for the Gleason grade group 2s. Even today, we're at 60-odd%. It's huge progress, but we are nowhere near where we need to be. And there's extreme variation at the level of the urology practice and urology practitioner in terms of comfort with surveillance and likelihood of a man actually going on active surveillance. Not only that, there was a presentation from the Chicago group, Scott Egner, looking at comfort levels with active surveillance, and it's kind of shocking how many, even sort of self-described academic urologists censoring a survey, still don't recommend surveillance for all low-risk disease. So there is still a major problem with overtreatment of these cancers, and this is certainly true in the US. It's true in other parts of the world as well. I realize it's better in the UK, better in Australia, but even, you know, even within Australia, from you know, at least last time I was there is variation from locality to locality and center to center. Still surgery happening for Gleason 3-3, radiation therapy, focal therapy, et cetera. So, you know, this is very much about what was the community standard, what is the community standard, and are there things short of surgery, radiation, focal treatment that, you know, may have a conscionable level of toxicity. Yeah, go ahead.
I'm about to explode.
Yeah, me too.
Yeah, exactly. But I'm seeing Keith going, I'm going to say something. Go on.
Matt,
let's all go.
How is enzalutamide better than, like, how are we, you know, reeling people back into active surveillance by giving them a systemic anti-cancer therapy with really bad side effects? It's only been seen in metastatic cancer. How is that better than localized treatment? And it's not curative.
I don't think that's what
how are we de-escalating? How are we de-escalating?
I don't think that's what this trial was intended to do, actually. You know, this is not about recapture. First of all, you know, there was a lot of discussion before the trial, you know, what is the optimal duration? You know, there was a lot of discussion, is a year correct? You know, should it be less? Should it be more? You know, there is a concept that if this was really going to take off, you know, a couple things. Number one, you know, should it be cyclical therapy? You take it for, you know, a month, a year, or something like that. Very different trial, obviously. Or is systemic the right way to do it? You know, Neil brought this up on the Your Amigos podcast. You know, local delivery of these agents is something. It's actually, the company he mentioned is actually a spinoff from UCSF, Penn Munster here. You know, the idea
Are you
of
okay, Declan?
these treatments.
He's all right. He's just having a little heart attack. Keep going, Matt.
I know there's some trials going on in Australia about this. You know, giving these medications locally, maybe another form of focal therapy, as it were. So look, I am not, again, this is not something that we're going to do at UCSF. It's not something I'm going to do. But if you tell me as a, you know, is it better to do a prostatectomy for Gleason 6 cancer, or, you know, or potentially use systemic treatment? I'm not sure that we have that answer. That's not how the trial was done, right? But I think the hope was to try to, what the hope was, I think, was going to be that there would be more of a pathologic response at the 2-year mark, and that by doing this, we could really kick the can further down the road such that radical therapy would not be necessary or could be delayed very substantially. Can we conclude that based on the current study? I'm not entirely sure, but Go ahead.
But the thing with surveillance is not to.
We're all just kind of here with our mouths open.
Yeah, it's
look.
Where's old Matt? Where can you bring out the old Matt?
It's almost like you are. I mean, uptake of active surveillance is definitely a challenge. We've all recognized this, as you exactly. But I feel like this goes against the. This is holding back the active surveillance clause. You're basically saying that there are patients who may seek other treatment, and we are going to try and prevent them from seeking other treatment by giving them treatment.
And maybe this is better than the unnecessary prostatectomy, but wouldn't you think that the solution to the problem is, do active surveillance better, support clinicians and
manage their
better.
expectations and their anxieties.
Not overtreat.
Don't give them a toxic candy to bribe them
and I'll give
not to go into active.
I'm just thinking of it. There's a very nice trial that we finished here last year. In fact, we had them on the podcast. It's a trial called the Navigate trial, and Navigate was a prospective randomised trial of patients eligible for active surveillance, exactly like this, low risk or favourable intermediate risk, and it was run by psychologists, by Penny Schofield and team, and it was based on exactly as we all agree, the fact that some men and clinicians can be anxious about this. So the standard of care arm was people get literature from the Prostate Cancer Foundation of Australia to support the role of active surveillance, so what you might get in community practice. But the intervention arm had an extremely well-resourced website called the Navigate website, beautiful videos where you would literally click, and you do quality of life measures along the way. What causes anxiety? Are you worried about sexuality? Are you worried about death, etc.? And there were all these videos about intervention as well as about treatment. And the study is due to read out very shortly, but the aim of the study was to see in men and their partners going on active surveillance, would enhanced surveillance, would a better resource to support your decision, improve your well-being, decrease your stress levels, et cetera, but wouldn't you think that's a better thing to do to try and make active surveillance more acceptable and less stressful for people, rather than say, let's over-treat the same group of patients? Keith, maybe you pitch in. I know you wanted to say something else about that.
I mean, that's exactly where I'm going. I mean, let's kind of look at the elephant in the room, and that this was a trial that was, funded by a very big company that made this drug. And, the disclosures of every author works with it, as Matt said. And, this is money that could be much better used elsewhere. Like you said, you getting resources in the community, rather than giving enzalutamide, which, in 2015, I know Pranay had a quote, this costs something like $130,000 a year if you're going to use it. Why are we not using all of these medications to go into the community and make people more aware about active surveillance and comfortable with it, or giving, more? You got a soundbite I can see that you want right now.
Well,
because it's a good thing you brought that up.
While you're on your point, because the cost thing is one thing. I think it's very secondary to the whole principle of over-treating this group of patients, but Vinny did the calculations. This is what he said.
The number needed to treat here, if you just looked at therapeutic progression, is 27, which puts us in at $4.4 million of enzalutamide to avoid one therapeutic progression, whatever that may be. This is pretty much the dumbest calculation I've ever seen. There's no health system on earth that would be so stupid as to ever make this calculation. You'd bankrupt your society, you'd overdrug your population, and you would barely be avoiding these events in the future.
There you go. Yeah. And this is in the US where that sort of stuff seems to...
But at the same time, as you said, giving people a systemic therapy in a study which showed 90% adverse effects, yet in the manuscript wrote that it was well tolerated compared to metastatic men. It completely glossed that over. And also using a therapy that we actually use as an endpoint in primary therapies to avoid. So I'm so confused. I have so many questions.
Even if you just look at
Matt being...
if you just look at the... Sorry, go ahead, Keith.
Matt being like the godfather, absolutely huge advocate of active surveillance for 20 plus years. I feel like it's my dad just told me Santa Claus doesn't exist anymore.
Oh.
So, it's not being,
Now again, so
It's a bit like that.
so like first of all, we ran a trial.
What is it
you know,
telling patients
yeah,
that we might not trust active surveillance by giving them enzalutamide? You know?
that is not the point here. It really is not. And first of all, I could not agree possibly more that the right move is just doing surveillance better. We actually ran a trial just like what you're describing, a 2012 DoD grant, doing exactly this, better web support. We actually had live coaches as well, helping men come to better decision making around this diagnosis. We agree completely. I would also say the reality is we're not getting that message out to the community, and we've been trying for many, many years. We and lots of other centers have been trying to get this message out to the community. I think there's some sense that what really kind of forced American urology to finally change was the U.S. task force. The notion that if we didn't stop overtreating, we were never going to retake the conversation about screening, which I think was quite largely true. I'm sure there were other factors that led to the task force revising their statement, but they explicitly cited the capture data that active surveillance rates were improving in the U.S. in going from a D to a C. So and despite that, we're still at 60%. So we can shout until the cows come home that everybody should be on surveillance. And again, in my practice, this is where I'm at 95% or more of the grade group 1s and a very high chunk of the grade group 2s, these low volume 3/4s, go on AS, and it's not augmented with anything, any other systemic treatment or focal therapy or otherwise. I think there is a broad problem out there with overmanagement of these patients. I think there's a over discussion of focal therapies, of surgery, radiation, all the rest of it. And again, I'm not advocating for enzalutamide as an alternative to active surveillance for these men. I think the point here was to consider an alternative, for situations where men are just not comfortable. Now, again,
so you're treating discomfort with enzalutamide? We
treat discomfort with proton therapy too. Let's be real. Okay, I'm totally serious. Now, talk about a waste of healthcare resources. I'm not saying that this is going to be a big part of our practice by any stretch. I'm saying if you think about how we manage low risk disease as a society, certainly in the U.S., and I look at this toxicity profile and the cost, is this something that we're going to do in academic practice or in any of our practices where surveillance has been our standard of care for a decade? Probably not. But, compare this to IMRT for all these patients, cost is not so different and the side effects at least are reversible. So I'm not advocating for it to be used routinely. The point here is, as a interesting alternative. And look, I would also make the other point that, to my knowledge, nobody at Astellas is going to the FDA or the NCCN to get this, onto the standard of care. This is a phase 2.
Why else would you do this study though? This is, if all the authors are saying they're not going to implement this in practice, and no, there's no way this is going to go to the FDA. Do you really think Pfizer's not trying to get this in and put it to the FDA? I mean, and they're also, this has been looked at before. People, you mentioned the REDEEM trial. It's been looked at before. People have looked at bicalutamide. Morgan Repair's group reported Lupron in these patients, so it's not the first time. And all of a sudden, this is published in JAMA Oncology and funded by Pfizer. And I agree with you. We need to do better. But how is saying enzalutamide is that? But we're just looking at alternatives. Like, how can you put out a paper and have your name on it, and then people in the community are now going to see this? They're not going to talk to Matt Cooperberg and say, oh, but he's not going to do this. This is just exploratory. They might see this and be like, now I'm just giving enzalutamide to everybody.
And the uptake of it doesn't have to be high. All it takes is a small population of physicians and patients to take up this drug. I mean, just looking at the toxicity profile, if you look at all the toxicities, there's one in 5 patients have erectile dysfunction. A quarter of the patients have breast tenderness. Over half of the patients have fatigue, which is serious. It has a serious impact on quality of life.
30% gynecomastia?
35% with gynecomastia.
30% with breast tenderness. So you say to the patient, you've got grade group 1 prostate cancer, we're going to put you on the drug, you're going to be very tired, your breasts are going to be sore, you won't have good erections, but your PSA will go down a bit, and then after a year it's going to rocket up again, because that's the other thing that maybe Keith wants to talk about that. But the toxicity is pretty severe, and I think we have to stop talking about, well, the alternative is, of course, they might get inappropriate treatment, but isn't the answer make people feel more confident about surveillance rather than pushing down the PSA and making them sore and tired. And Neil on Euromigos was saying, oh yeah, but you can treat the gynecomastia with a bit of radiotherapy. A bit of radiotherapy to the breast, geez, we're now on the slippery slope of don't worry about that. 1 in 3 chance of big sore breasts, but your PSA will go down for a while,
and we can radiate the breast.
We can radiate the breasts, yeah, exactly. So yeah.
And if you're giving this to anxious patients already, that PSA rebound that you see, that's going to prompt patients to continue the treatment forever.
What do you think about that? Because that graph
that was impressive,
in the paper that you were on treatment for a year, and yes, statistically the PSA came down in those men that were on, but then as soon as he came off it, it rocketed up, didn't it? This graph here for those
just the minute you stop enzalutamide, it just crashes, and I think that's somewhat predictable. I think the authors knew that would happen, but I would think that would increase anxiety for sure.
Yeah, and maybe push people into proton therapy or whatever it's going to be.
So push them into therapy.
I mean, it's just terrible. And whereas if
are we masking high risk disease as well? There are some of these, PSA bounce is a real masking of high risk disease, and are they going to develop it when they wouldn't have otherwise? I don't know, but.
Yeah, Matt, on Euromigos yesterday, the other thing that Neil Shore, I should say, we're talking about, who's a very experienced clinical trialist and a good friend of ours, and spoke very well about it. But he was asked, what next on the podcast? What are the lessons from this? Because the conclusions are pretty optimistic about it, And I should say this paper was written by medical writers employed by the company. 3 of the authors are employed by the company. And they wrote that the conclusion and relevance, the results of this randomized trial suggest that enzalutamide was well tolerated. I don't know how you would agree with that, to be honest with you, compared to just doing nothing. And demonstrate, it's not like you're comparing with chemo, you're comparing with just be normal, and demonstrated a significant treatment response in patients with low risk or intermediate risk cancer. And again, that's back to the endpoint thing. Would we all agree that's a significant treatment response? I'm not sure. And finally, this is the bit, enzalutamide may provide an alternative treatment option for men undergoing AS. Which has got a lot of reaction on Twitter because most of us would feel that is not an appropriate conclusion from a paper of this nature. But when Neil was asked where to next for this, because that question about, for example, is 1 year enough, as you talked about earlier, Matt, and so on, here's what he had to say to Euromigos.
A, should we give the therapy longer?
Oh.
B, is enzalutamide the best AR pathway inhibitor to give long term?
Please don't do this in another drug.
C, how do you balance longer utilization with the AE profile?
More radiotherapy.
And also, is there another way to administer an AR pathway inhibitor to the prostate other than giving it orally, systemically?
And he goes on to talk about a trial he's running where you inject little pellets of AR blocker into the prostate. I was asked to do that, so I said, I don't think that's a good idea. But Matt, you mentioned it earlier, maybe you're doing that as well. But anyway, the point is, or E, no, A, B, C, D, E, don't do anything else. Just put them on active surveillance. Maybe why don't you fund psychology and support groups for patients or websites that make you feel more confident, and then your quality of life will be not impaired by this freaking, quite significant side effects of enzalutamide.
Matt.
I mean, look, if I had the pharma budget to direct, where I would, the world would look very different. Okay. So, and like I said, we have done that grant, and, it was positive and it was wonderful, and it had no impact on community care whatsoever. So, and again, am I arguing this should become a community standard? Not at all. And I don't, like the paper's written the way it's written, and the conclusion is what it is. I would be very surprised if this really does drive practice in this current form. I do think this notion of locally delivering biologics to the prostate is actually very interesting. It's a breast oncology colleague of mine here that has launched this, Penn Munster. It's, the trials are actually happening in Australia. There's this company that Neil mentioned has spun off from it, and there's actually a lot of appeal to that concept of local pharmaceutical delivery, avoiding all the side effects we've been talking about, and giving it over time through a controlled release. This becomes another form of focal therapy, which, in theory could actually stand up pretty well against some of the other ones that are out there. So I mean, that's much further upstream.
But you mentioned earlier as focal therapy, like being one of these things that people are doing as a crutch for active surveillance. So isn't this injectable? It's the same thing.
In the right patient. I mean, we're doing more like
more
both centers. We're increasing our focal program, but we're very selective about it. It's grade group 2s, it's MR visible, we're ultrasound visible, it is, we're doing genomics on everybody, et cetera. There is obviously clearly there is a band of patients who will benefit from something in between active surveillance and radical whole gland therapy, right? In the context of a practice which is very comfortable with active surveillance, is systemic enzalutamide the answer? No. In the context of a practice which is otherwise treating all these men with irreversible whole gland therapy, should they just adopt active surveillance? Yes, of course they should. And we should see a 95% national adoption rate for AS, but we don't have that. So is this a crutch, or is it a mechanism for, for someone to allay anxiety, et cetera? I don't know. Maybe it is not, it is not the worst. And again, this is not something that fits into the UCSF paradigm, or I think any of our academic paradigms here. But relative to everything else happening for prostate cancer, I mean, you hate to endorse a trial by saying it's not the worst thing out there, but it is by far not the worst thing out there in my view. I'm serious.
Yeah.
You compare this to.
It's pretty bad though.
Yeah.
I mean, it's systemic. Yeah. It's up there.
It's up
It's
there.
up there. Yeah, I mean, it is.
It's a shame though, isn't it? Because, patients who have low risk and favourable intermediate risk prostate cancer, they're this sacred pool of patients where we can actively do no harm. And we really should be putting our efforts into improving active surveillance uptake,
Yes.
seeing what we can do for patients to retain them in active surveillance, improving their education, managing their expectations and their anxieties.
Reassure them that
The
if they're
effort needs to
cancer-
be on us
And-
as doctors
Look,
rather
but
than...
Also,
I'm on record. We just wrote the editorial saying we shouldn't even call these things cancers.
That's
okay? So,
exactly.
Yes.
yeah.
Right.
Well, you'll be
But
back
that's
in
not.
trouble.
But that is not yet the world we're living in. As much as I want it to be.
Yeah, not sure is this helping. This
That's
paper.
the thing. In a time when we're arguing whether grey group 1 is even cancer,
So if
this
someone
doesn't help the cause.
If someone comes in next week into the clinic, Matt, and says, Dr. Cooperberg, I've got you have to have 3 cores. I've got 4 cores of grade group 1 prostate cancer. My PSA is 5.8. I'm 66. I'm meeting 200 criteria. I've got the money. I would like to have enzalutamide. What do you say to that patient?
He's going to walk out on active surveillance, and I can tell you that with 100% confidence based on.
But Matt, you did mention in some of your
But again,
tweets-
that's my program. We've been doing this longer than anybody.
I mean, Matt, you did mention in one of your tweets that you could see the rare clinical scenario where this would be useful.
Yeah.
What would be an example of one of those?
The fact is, as much as we've been talking about these AEs, and they're not insubstantial, they are reversible, which is not something that can be said for the AEs from surgery and radiation therapy and even focal. So, somebody with, high volume, really high volume grade group 1 or limited grade group 2, who is, for whom active surveillance is a temporary proposition. I talk to these men when they're younger that the question of treatment is when, not if. When may be way down the road, but it is when, not if. And, for some men who are still a few years away from coming to terms with a treatment decision, could this be a way of kicking that can down the road? Potentially, for a very selected subset of men, somebody for whom surveillance, maybe somebody with a high genomic score as well, where we're really kind of teetering on the suitability of AS. Is the enzalutamide going to cure the cancer? Absolutely not. Is it going to solve all the problems? Absolutely not. But from the standpoint of managing anxiety, am I likely to do this? Probably not, is the reality. But I can see certainly plenty of contexts where the reality is the urologists are still not comfortable doing this. They should be, but they're not. The patient should be comfortable, but they're not. And we're not. We can launch websites, for the next 20 years, and we're not going to solve community variation here. Is this a way of buying time? Maybe.
I thought active surveillance was a way of buying time.
Keith, what
Yes.
final thoughts on this? I thought Matt would roll back in. He did a bit, but he didn't. And I thought he'd roll back in a bit. Said, no,
You're very brave, Matt.
I thought he would say this should only be done in a clinical trial ever. This trial is not good enough. So
I don't think this will be approvable. I can't imagine an insurance company covering it based on this phase 2, at least not in the US.
Yeah, the problem is sometimes people will go around that and off trial or
Yeah,
overseas.
people
And
pay cash.
that's right.
Look, I mean, yeah.
Yeah.
This is
And
not even the most
we can talk about
shocking
patients flying,
useful.
Yeah, that's right. In the what next, actually, Neil mentioned he has a trial ongoing where they're doing the same population, but they're giving them sipuleucel.
Sipuleucel.
So that one, we can come back and talk about that one when it comes out. I will say one thing for that one, which is that the concept with immunotherapy has always been bending the growth curve in the long term, as opposed to radiotherapy therapy.
Oh God. Oh, sorry.
I'll tell you a story about that one.
Are you on
at
that
some
trial?
point.
He's on that trial as well,
Oh
Keith.
no, man.
I'll tell you a story about that.
I
one.
know. Yeah, he's on
That is a longer story, actually, and I think I was under the impression that's a while away from publication, actually. But
Okay, good. We have
anyway,
time
But
to
I just
recover.
don't get it. I mean, we're trying to tell patients that this is not cancer, that this is safe, and we're talking about giving them Provenge. You know, it's an enzalutamide. Like, these are for advanced metastatic patients.
Yeah.
And then we're leaving out the patient.
They are.
That's who we're
Provenge,
talking about.
this is a whole different conversation, but I mean, Provenge, the trial we were really advocating for with Provenge was a bigger neoadjuvant. We ran a small neoadjuvant UCSF years ago that did show pathologic effects. Bigger neoadjuvant in high-risk disease makes a lot of sense. So the earlier you use immunotherapy, the better. This is a whole different conversation.
Oh God.
We're talking about active surveillance population here, and this cohort in Enact was 80% low risk, right? And I think it's this intermediate risk cohort that we really struggle with. The ones who are teetering on treatment, high PSA densities, IRADS 5 lesions, maybe they have high genomic scores or something like that. I think that's where you might potentially have a space for something like this, where you really don't want to go towards therapy. But still, this was an 80% low risk cohort. And I just worry what this is telling patients and what this is telling community doctors. They're not all going to have this conversation, and they're going to see this in JAMA Oncology as a phase 2 trial.
And the problem with how this paper is written is they keep mentioning active surveillance augmented by enzalutamide, active surveillance plus enzalutamide. One negates the other. It's
not active surveillance.
No longer active surveillance. It's active treatment.
I wouldn't argue with that at all.
Yeah, that was written by
the only I would say the only caveat to that being if you do take Redeem as the comparative standard here, is dutasteride treatment. Probably not, but it's obviously different, very different drug, different side effect profile. Is that still surveillance if you're on dutasteride? We all say yes. I'm probably one of relatively few people that will actually use it sometimes in the AS setting if patients got a lot of LEPs and a PSA out of proportion to their pathologic findings.
But in Redeem, the adverse events were way lower.
Of course, it's 5 ARI. Yeah, of course. It's a totally different thing. But it's also long-term therapy.
Shall we finally hear, what did Vinay, he had one more thing I wanted to share with you.
I would encourage Pfizer
Does
to
he get the last
your
one?
ill-gotten gain some other way, you don't need to go after the active surveillance population. I guess the takeaway point is obviously this is stupid. Obviously, nobody should be on a horrifically expensive anti-cancer medicine. Hundreds of people taking a horrifically expensive anti-cancer medicine, so a few people someday, years down the road, don't need some other treatment. That's a silly proposition.
Yeah, kind of agree. Yeah.
What do you reckon, Declan? Active surveillance augmented by a couple of shots of
I
lutetium
think
PSMA?
I'm a very simple person. Keith said he likes reading simple things. I just think active surveillance is active surveillance. If a patient's eligible, they should be on active surveillance. None of this augmented stuff like that. But there you go. And look, thanks, Matt. Thanks, Matt, for coming on. And I can, there's the usual opprobrium on Twitter. It's very imbalanced as well, some of it. So it's great to have you on, of course, as a valued investigator, expert in this field, and a great friend of us and the podcast to talk about it. And I think it's helped a bit, but I don't think it helps me change my view on this, that this is terrible. I personally don't think there's any forward message on it. I think active surveillance is active surveillance, and I do worry a little bit that this might lead to some patients being harmed because it might raise some expectations. That's my
and in fact,
view.
you can use that second graph and the toxicity table to really talk patients into active surveillance. I mean, that's the only positive I think you can really kind of take away.
And I'm now getting more anxious about these other trials that we're probably going to have to deal with as well. But I think active surveillance patients should not be having any sort of intervention, let alone active surveillance augmented. But Keith, your final words on it.
I mean, I think I've said what I have to say. I mean, I just think this might be a slippery slope. I know, it's a phase 2 open trial label open label trial just to see, is there an alternative to community? Apparent from what I'm gathering is that the authors want to know how to increase community uptake of active surveillance, and apparently that's giving enzalutamide possibly or something like it. And I just, even though I don't think it's exploratory, you publish this in JAMA Oncology, and that's going to go a far way in some people. And again, it's a slippery slope. I'm sorry, but I don't trust pharma here. Why would they be doing this study other than to push it through the phase 3 and trying to get FDA approval? That's just my opinion. And I'm worried that I don't question the ethics of any of these authors. They're all very smart people, and it was IRB approved, but we're really on the line of do no harm here. And I think these patients were harmed, and they signed informed consent, and that's fine, but Matt, I love you, but I don't want you to involve in any more of these studies.
Yeah, exactly. Look, thanks
Wise
so much.
words. Let's leave them alone.
Yeah, look, thanks very much to both of you gents. Hopefully we'll see you around in person soon. We're going to see Matt next week, are we?
EAU, see you soon, Matt.
See you next week.
I look
Matt.
forward to it.
Yeah,
Great to see you, Keith.
In Amsterdam.
We will buy you a beer for this. Yeah, great.
Something stronger,
Enact. Maybe don't enact. What's the
Don't enact.
Don't enact. That's
Don't
it.
enact.
Hashtag don't enact is going out on this one. But thanks very much to Matt and Keith Kowalczyk for joining us to talk about this today. We'll be back with you again very soon with some conference reporting from USENS and from EAU in the next couple of weeks. Thanks very much and goodbye.